really trying to figure out if we can make all of these jobs a little bit more attractive. And same thing with physicians, is take away some of the jobs that we don't want to do, that doesn't require our skill level, that we're forced to do. And I think that's what we're hearing from our younger physicians that are a little bit more insightful, that I don't want to do this anymore, or I don't want to do this job anymore. And I think we have to listen to them, and I think they have to speak up and make those suggestions.
Thank you. I just want to make a short comment on the availability of staffing and the future of emergency medicine. Basically, when people go through programs and they graduate and they train and they work in different sites, as we move along, throughout the years, some people they find that they have probably different interests, like in finance, in legal, in admin, or even in the specialty of emergency medicine. They look at emergency medicine probably at a stage and they want to do something like, something more outdoor, like wilderness, or even something like special operation medicine, like HIMSS and medevac and all that. So I think this is a tool that probably institutions around the world want to tap into. First of all, to avoid burnout for emergency physician. Second, to explore other skills that an emergency physician or an individual or a nurse or an EMT or a paramedic has at a stage that he was too busy during his residency or the first few years of establishing himself, is actually to have probably an international umbrella to train people like that and put them in a more probably accredited programs. Not only this will feed back into emergency medicine and disaster and global event, but it certainly would probably have a better response in terms of disaster like flooding or pandemic, or even unify the scope for payment, for example. And that's just a thought.
If I can pick up on two things, I think there's been some really great points made. So in our nursing system, we already operate on a 3-tier structure where the RNs are the chief nurses. We have nursing auxiliaries and staff nurses, which range from a year to 2 years to 4 years of training, and then there's specialty nurses on top of that. The difficulty that often comes is that from a financial perspective, the hospitals see that why would they need to have any registered nurses, because the physicians can take over that role, and then you're paying a lower salary. So we found that we've not gained much from that. And with regards to, I think it's an amazing thing to be able to allow staff to develop in areas of their interest. The difficulty often, and I'm sure we've all sat when you're running departments going, yes, I want to support an individual, but in supporting that individual, I could threaten the rest of the team. And that is often the difficult tightrope that we are needing to walk. I am also quite staggered that there are more graduating emergency physicians in the US than there are on the African continent. And that's you graduating those numbers each year. But it brings me to my second question for you, Paul. You've stated that emergency medicine in the US is 50 years old. It's one of, or not the oldest country, or not the oldest country, shall we say the grandfather of emergency medicine as specialties globally. So it's something that we've not faced before, is looking at how can emergency physicians work until retirement at a pace that is often required in busy emergency departments. And the natural progression has always been into leadership or academics or something like that. But do you think that emergency physicians can be a pit doc till the age of retirement or death, whichever comes first? And I do note Lewis has got a question, so if I could ask Paul to answer that, and then I'll take Lewis.
I think, Roger, this is a great question, is can you be a pit doc till your 60s? I have to tell you, I've worked alongside a lot of the physicians that I worked with were 60 plus. And I have to tell you, it's a more difficult job as you get older. I'm looking into the audience, and when I was 20, 30, 40, 45, doing a night shift was easy. It's more difficult now that I'm in my mid-50s. And I still do them from time to time, but they're much more difficult than I recall them being when I was younger. So I think the issue here is there probably needs to be some type of seniority for the older emergency physicians, that they work less nights. And so I think that is probably the best solution. Maybe they work a few more weekends and a few less nights. I think that seems to be the right mix. That also takes off a little bit of the younger physicians that have time with their kids during the weekends. So I think that's the mix right there. It's, not a perfect system, but I think that's how I would address it.
Thanks. You've got a microphone. Great. Thank you.
Hi, I am Carlos from Mexico. They are the grandfather, but we are the second one. We have 37 years, and we had 37 years of emergency medicine in the world, so we are the second one. One of the things happening in the emergency medicine is that we need to tropicalize the emergency medicine in different countries. Every country has its own problem. So if you try to compare with the United States or with France, they have problems for the States because the medicine practice in the States is defensive for the States. If they don't do it correctly, they sue, and they have big problem for this. So I think the emergency medicine, I see the evolution for the 37 years. So at the beginning, like Paul said, we have less tools and we resolve the problems. Now we have a lot of tools and we make more mistakes. Why? Because if we have, one of the things happen is when, I remember 15 years ago when in Bahia, Gunnar Ollner, probably you know Gunnar Ollner, was the president of the SEM. At that time, he came to Puerto Vallarta in Mexico and he said, well, now in Switzerland, we are closing the emergency room. And say, you are closing the emergency room? We are overcrowding all the time. How you can do that? So, because they start to organize long time ago. But when you compare this with the countries like Mexico, other countries in Latin America, also in the United States, all the time they are overcrowding. You see in the States, patients start hour and hour waiting for something. In Mexico, if you go to the emergency room, you need to wait 1 week or 2 weeks to get CT. So I think every country has its own problem. My suggestion is, first of all, we need to see. Europe, they don't have all countries recognize the emergency medicine, first of all. Second, for example, Spain, 4 weeks ago, they go to the Congress, and they don't accept it. But they have fighting for 25 years or something like that. Eric, you know better than me how many years they're fighting, but they don't recognize. So we need to training that the people is working in the emergency room. I know many people is general practitioner, internalists, but if you want to work in the emergency room, you need to resolve the problem for the emergency room. So probably you don't want to be specialized, but you need to take the correct courses to improve your knowledge to resolve the problems, first of all. Second, who held the doctors in the emergency room? The nurse. Sometimes the level that they have the nurse between the doctors is too high, too different. So we need to prepare people to help the doctor to resolve the problem. Because sometimes, who make the triage? For example, in Mexico, you arrive, one people is secretary, he have probably elementary school, and she decide this patient is sick or this patient is not sick, and waiting. In similar countries happen the same. So we need to do something that the access to the emergency room need to be quick, good, gentle, and effective. But you don't need to spend too much money to do that. You need to prepare the right people in the right place, in the right hospital to resolve the problem. The pandemic showed us how important is the emergency room. At the beginning, we saved a lot of lives. At the beginning, we are heroes. 2 weeks later, 4 weeks later, the heroes was the ICU doctors. Excuse me, we take the care for the patients, but they don't remember exactly what's going on. So if we work together, we'll be stronger and better, and we can resolve many problems around the world because we are similar ideas, similar knowledge, and work together and be successful in the couple of days. We need to make re-engineer to create ways in the wayside to fix it, the holes that create the pandemic in the emergency room and also in the system.
Carlos, thank you. I think there's some, if I can pick out some very important points that you've made, is that I call it the hero to zero phenomena, and it's something that we face in emergency medicine all the time. And you've encapsulated it well with how it applied in the COVID response, is a hero 1 minute and a zero the next. The second, I think, is the way that emergency centers, emergency departments are being used by the population is often a reflection on the expertise that are perceived to be there. And it's something that's being picked up by Eric in his presentation and by Paul and Srinath, was that we are seeing an increase in the number of emergency department presentations in favor of other areas within health systems. And that may be from a financial perspective, it may be an availability perspective, but I think a lot of the time it is seen as an expertise. If they go there, they will get the problem diagnosed and sorted because that's what emergency physicians do. There's also a perception that they will wait less time, which I don't think certainly if they've sat in my waiting room of my emergency department, that's certainly not true. But thank you for your comments. I think some very valuable input made there. Sorry, could we have the mic back on there? I can't hear you. There we go.
One point more. When you're talking about the retire, you need to think about it. What is the period of the time for the sport guys? For example, Messi, Cristiano Ronaldo, Jordan, they have one period of the time. 37 is all. Like Paul say, when do you try to work in the emergency room? I think the best time to work is at the beginning, 20s, 30s, 40s. And then you need to take other positions, like training, like teaching, but you don't need to go out all the time because you are the values that you have, you need to teach for the new guys. The new guys need to understand better than us to advance quicker and in the best way. Because one of the things happen now is that many of doctors, like you said, the burnout around Europe and around the world they affected our population. So we need to create, don't go away the old doctors, support for the teaching, support for the program, but stay there because you are very helpful for the system.
All right. Any more questions?
May I add a comment?
Yeah.
Yes.
Go ahead, Eric. Yeah.
A quick comment about to summarize what you said, and I agree with one main point that Roger said. We are always on the front line, and emergency medicine. The creation of emergency medicine was in 1974 in UK, and then in Ireland and USA, and that evolution of emergency medicine are still the same concept. We are on the front line. When we create the pre-hospital EMS in France, it was just because we had a lot of road traffic injuries and we have patients dying before they come in the emergency department. It's not the problem anymore. We reduce to 10,000 to 2,000 patients who die for road traffic injuries. But the main thing we have, with the exception of India and China, they still have a lot of concern, and Turkey, about the road traffic injuries. In Europe, it's mainly medical problems that are coming through emergency departments. But the thing we are facing for now is we still are pioneer of emergency medicine, and we live day after day a new concept. Take the example of the COVID. No one in the room, and no one like myself, have faced the pandemic like that. We were the first to face that, and we deal with that, and we try to organize. So emergency medicine is also to adapt our system to the disease that like we have, and we will have to face it. And I agree with Carlos Garcia, as he said, that we do have a lot of things in common, but we have to adapt our system on our own system of our own country, because we have a different concern about the system. I will be really lucky to take the example of the emergency physician in USA. I would love to have a huge number of emergency physicians in my department, but we don't have, so we try to find some issue for that. But that's very interesting talk we have together, because I think we still are pioneer of this creation of the specialty. Thank you.
All right. Thank you, everybody. Thank you.
Enjoy lunch.
Thank you, guys. Take care.
Thanks, Eric.
Bye-bye, Eric.
Bye, friends.
And I want to give the mic to my close friend Hikmet from Atayurdu, Uzbekistan. We are in very good collaboration between Turkey Emergency Medicine and Uzbekistan. Yes, Hikmet, please.
Thank you very much. Yes, indeed, we are collaborating for more than 5 years, and it's a great honor and pleasure for us. It's quite challenging to start after lunch session as usual, and this is an endless battle of curiosity with physiology, but nevertheless, let's start. So, as Bajar Hojam has said, it's our really great pleasure and a privilege to invite here Professor Josep Brugada for his topic, Sudden Cardiac Death. Por favor, tome la palabra.
Thank you very much, Dr. Andarov, Dr. Kander, very...
This one next page.
Okay.
Next page, and laser. You
This laser?
push, yes. Hold push button. Yes.
Okay. Thank you very much. So I will talk in the next minutes about sudden cardiac death, and I will try, first of all, to remind you the definition of sudden cardiac death, which is a form of death which is natural, which is due to cardiac causes, unexpected in time and form of presentation, that is always preceded by sudden loss of conscience, that happens in the next hour after initiation of symptoms, and this happens in someone with or without a known cardiac condition. As you know, the final rhythm that produces sudden death is, in the majority of cases, ventricular fibrillation. But there are other rhythms that might lead to the same situation, which is the asystole, complete AV block, or electromechanical dissociation. But basically, in our interest, the most important one is ventricular fibrillation. Practically any form of cardiac disease can, at the end, produce sudden cardiac death. but basically we are dealing with ischemic causes, with myocardiopathies like hypertrophic, dilated, or arrhythmogenic, but also some electrical conditions like the long QT, the short QT, Brugada syndrome, but also other conditions like the postoperative congenitals, cardiac amyloidosis, etc. All of them at some moment can produce sudden cardiac death. So if we talk about ischemic, we're talking about #1 cause of sudden death in our environment. In Europe, #1 cause of sudden cardiac death is acute myocardial infarction. So during the acute phase of the myocardial infarction, the cells get with ischemia, and they complain about this ischemia by having pain, but also by producing ventricular arrhythmias that can produce ventricular fibrillation and sudden death. So if we want to fight against sudden cardiac death in our environment, we have to fight against acute myocardial infarction and prevent acute myocardial infarction. When we are dealing with patients that have already gone through an acute myocardial infarction and have survived the myocardial infarction, in the chronic phase of the myocardial infarction, there is also a risk of having sudden cardiac death because of the occurrence of electrical circuits in the area of the myocardial infarction. The bigger the myocardial infarction, the most chances that during follow-up ventricular arrhythmia or sudden death might occur. Although in the last years we have learned that it's not only a matter of the size of the myocardial infarction, but you see here that a small myocardial infarction, very homogeneous, is a non-arrhythmogenic scar, but also a huge myocardial infarction, but very homogeneous, it's also non-arrhythmogenic. On the contrary, you can have a small myocardial infarction which are very inhomogeneous, or large myocardial infarctions, very inhomogeneous, which are really arrhythmogenic. So the point is that probably in the future we'll be analyzing the risk of sudden death in a patient post-myocardial infarction, not only because of the size of the infarct, but on the quality of this infarct and the survival of cells producing an inhomogeneous scar, which is more prone to arrhythmias than an homogeneous one. When we're dealing with dilated cardiomyopathy, we're dealing with probably what has been called the pandemic of the 21st century, because the increase in the number of patients suffering from cardiac insufficiency, dilated cardiomyopathy, because of the increasing age of the population, increasing risk factors like hypertension, diabetes, obesity, etc. Remember that 50% of the deaths in patients with dilated myocardiopathy are sudden death because of ventricular arrhythmias. So we have to treat the cardiac insufficiency, but also we have to prevent the arrhythmias in this population. When we're dealing with hypertrophic cardiomyopathy, here we are dealing with a genetically determined disease that produces a hypertrophy of different parts of the muscle, and this hypertrophy produces arrhythmias, many of them ventricular, many of them polymorphic, and many of them lethal, that might kill the patient by sudden cardiac death. And remember that hypertrophic cardiomyopathy is the principal cause of sudden death in patients younger than 40 years of age, especially sport practitioners. We also have arrhythmogenic right ventricular cardiomyopathy, which again is a genetically determined disease that produces changes in the muscle, basically in the right ventricle, but also sometimes in the left ventricle. And these changes produce the occurrence of islands of tissue in this muscle being the basis for the occurrence of ventricular arrhythmias and sudden cardiac death, again in young population and again in sport people. However, there are a number of patients, around 20%, who had sudden cardiac death but do not present with a structural heart disease. They have a normal heart, and these are the patients like this one having ventricular fibrillation but a completely normal heart. In the last 30 years, we have learned about a new category of diseases that was unknown to all of us 30 years ago. That's what we call the channelopathies. And the channelopathies are the long QT syndrome, the short QT syndrome, the Brugada syndrome, catecholaminergic polymorphic VT, or malignant early repolarization. All of them are diseases that were unknown to all of us 30 or 35 years ago. And we understood that by looking very carefully at the electrocardiogram, we could identify some signs in the electrocardiogram that were explaining us that something was wrong in this heart, electrically speaking. Why we call that channelopathies? Because these are diseases which are familial, so they are genetically determined, but affect the channels that regulate the flux of ions across the membrane. And these channels, if they have a mutation, they will not work properly, and they will produce some signs in the electrocardiogram, but also might produce some electrical gradients in different parts of the heart, these electrical gradients leading to the occurrence of ventricular arrhythmias and sudden death. This is a patient with a long QT. Please look at the very prolonged QT interval, 640 milliseconds, corrected by the frequency at 584, extremely prolonged QT interval. When we have this type of ECG, and this ECG belongs to this lady here, you see that 7 members in her family have died suddenly because of the prolonged QT interval, and she was the only survivor in this family. So it's a very, very malignant form in this family of the long QT. This is a patient with Brugada syndrome. Look at the ECG, which shows this ST segment elevation in right precordial lead, simulating a myocardial infarction, which he has not. And when you find this type of ECGs, there is the risk in some patients that ventricular fibrillation occurs and the patient might die suddenly. Again, we're dealing with a familial disease. This is a family with Brugada syndrome. This guy here died suddenly. There are other 8 members affected in this family, and this allowed us to identify a mutation in the sodium channel that was responsible for the disease. This is the first patient we ever saw with the Brugada syndrome. That was in '86. In '92, we published the first paper. We defined the characteristic electrocardiogram. We understood the mechanism leading to these anomalies in animal models. We understood that the patient should be protected with an ICD. We could define in 1998 the first mutations in the families with Brugada syndrome. In late 2010, we could, for the first time, do some ablations in patients with Brugada syndrome in the epicardium, and certainly the future will tell us how to change the genetic defect in these families to normalize everything. Look, that it took 30 years to go from the initial description to the actual reality in the patient with Brugada syndrome, and we have learned a lot, we have advanced a lot in how to diagnose, how to risk stratify the patients, and how to treat the patients. We have also mutations in the potassium channels, like this one, producing this very prolonged QT interval. Look at this T wave, very abnormal, giant negative T wave in left precordial leads. This is a very dangerous situation. This is a very high instability from the electrical point of view, and this patient might go into ventricular fibrillation at any time because of this very highly unstable electrocardiogram and repolarization defect that might produce certainly some arrhythmias and producing sudden death. So when we're dealing with the long QT, we have the long QT3, which is the one affecting the sodium channel, but then we have the 1 and 2 that affect the potassium channel. So the result at the end is the same by different mechanism. The result is that the repolarization is prolonged, so the QT interval is very much prolonged, and at the end, ventricular arrhythmias, sudden death can occur because of this gradient between different parts of the heart. Also, we described in the year 2000 the short QT interval, the short QT syndrome. We saw these patients, these first initial patients in the year 2000, especially this one here, that was a lady, 25-year-old, that had a syncope. And we received the ECG of this patient, and we thought that it was a mistake because the QT interval in this patient is no more than 200 milliseconds, extremely short QT interval. So at that time, we asked for a repeated ECG because we thought that the machine was not working properly, and we received the same ECG, so we understood that this was probably the first case of short QT syndrome ever described. Unfortunately, this lady, this was a Friday evening, and we asked the lady to come to our hospital, but the lady was living 100 kilometers away, so she decided that she will come to our consultation on Monday because she had a very young boy of 5 or 6 months of age, and unfortunately on Sunday morning, this lady died suddenly. So then we learned that this was a familial form. Here you have some families with the short QT syndrome. Look at these very short QT intervals, very tall T waves, and very short QTs in families with sudden cardiac death. So probably this is the most malignant of all the channelopathies because of the very short QT interval. There is a huge window of vulnerability in these patients, and any arrhythmia, any extrasystole might produce ventricular fibrillation and sudden death. That's why probably there are very few patients described with the short QT syndrome all over the world, probably because they are dead. This is a polymorphic, bidirectional ventricular tachycardia, and this is specific from a condition called the catecholaminergic polymorphic VT. Again, a familial disease, genetically determined disease produced by a mutation in the ryanodine channel. The ryanodine channel is the channel that regulates the flux of calcium inside the cell. And during mental or physical stress, the flux of calcium increases. If the patient has a mutation in the ryanodine, this flux cannot occur, and there is an accumulation of the intracardiac calcium, and this produces an intoxication of the cell, and finally produce this type of arrhythmias that you see here appear during a stress test or mental stress test. This is the ryanodine channel and how the calcium accumulates inside the cell and produces this type of arrhythmias. Finally, the last situation described is what is called the malignant early repolarization, which occurs in patients having this abnormality at the end of the QRS complex, like an early repolarization that in some cases might be responsible for the occurrence of ventricular fibrillation. In some patients, there is an overlap between this early malignant early repolarization and Brugada syndrome, and still it has to be studied in the future. At the end, all of these diseases produce ventricular fibrillation because of this electrical gradient between different parts of the heart. So we can say that genetic studies have identified a new category of diseases responsible for syncope and sudden cardiac death in patients without demonstrable structural heart disease. That's what we call channelopathies. The good news is that if you look carefully at the ECG, you will find the signs to identify the patients at risk. So be careful and read carefully the ECGs and learn how to identify the patients that might be at risk. So, of course, in the patients that are recognized as patients at risk, we have to protect them. And we protect them basically by using implantable defibrillators. As you know, implantable defibrillators are extremely reliable devices that identify the ventricular arrhythmia and treat them very effectively in the majority of cases. But we know, and you know as emergency physicians, specialists, that time is what counts. So not everybody can be identified and can have an ICD implanted. The majority of patients that are at risk for sudden cardiac death do not have an ICD implanted because they have not been recognized. And we know that every minute that lasts, we have 10% less chances of surviving. So we need early defibrillation, and early defibrillation requires, of course, very good emergency systems, but also we need public access defibrillation that might allow for the general public to use these devices and to treat the patient waiting for the emergency system to arrive. There is a study in Japan that compares the number of public defibrillators installed in the countries and the number of patients that are shocked when they have a cardiac arrest. And of course, the more devices you have in the street, the more probability that you will be shocked by a bystander if you have a cardiac arrest. And this is my last slide. This is the number of deaths in car accidents in Spain all over the last years. And you see that they did a very good job, because you see that from the 60s we had an increase maximum in 1989, and since then the decrease is dramatical. So they did a lot of very good jobs, a lot of investment, a lot of money, a lot of fees, a lot of fines if you were too fast in the street, you were not having your protection, whatever. So a lot of money invested to go from almost 6,000 to 1,000. Do you know how many patients died suddenly in Spain? 10 times this number. And the number or the amount of money that is invested is 10 times less. So, of course, this is very important, because the politicians should also understand that sudden cardiac death is a major public problem, and investment in preventing sudden cardiac death should be at the level that it deserves for the number of patients suffering from it. Thank you very much.
Thank you very much for this great presentation. I think we can take the question, the last. Yeah, okay. Okay, thank you very much. We will take the question later. Okay. Yes. Now I want to invite the second speaker, Dr. Hikmet Anvarov, about aorta dissection.
Thank you very much. Herkese merhaba. So it's a really great honor to me to be here with you again. And as I've taught you this morning, The main focus in our hospital in Uzbekistan is on the ascending and descending thoracic aorta. Yep. Closer. Okay, is it good now? Thank you. So some protocol things, I have nothing to declare, only I would like just to stress the contribution of my angio and cardiovascular department in designing these slides. So the dissections of aortic aneurysm is, as you know, all the condition characterized by a rupture of the inner wall of the artery intima with the formation of the false passage for the blood. And about 50% of patients with untreated aortic dissection will die within 2 days, maybe, is a risk of death within the first hour for acute aortic dissection is about 1%. So time matters. In large medical study, including almost 1,000 patients with aortic dissection, almost a third of them died within 2 days, and 2/3 within 2 months, and almost 90% within 3 months, and almost all of them within 6 months. So it's really a huge problem. The frequency of occurrence due to several studies is it's about 3 per each 100,000 population, and average almost 1,000 cases per year in my country with a population of 33 million people. So all of us, we well known about the types of classification of aortic aneurysms. There is 5 grades by Svensson, and also the most common things is Stanford's and DeBakey classifications. So the aim of the study, what we held in this year in our hospital, it was to evaluate the direct results of the first experience in surgical treatment of ascending aortal dissection aneurysm type A by Stanford. So these are materials, the retrospective analysis. We had 6 patients which we underwent for the surgical interventions, because the closed transcutaneous interventions has been described on the morning sessions. I would like just to stop more on the surgical ones. So 2 of these 6 patients had concomitant ischemic heart disease. In one case, we obtained grade 3 of aortic valve insufficiency, and in one patient also the intimal tear was located on the proximal part of the aortic arch. So also just were performed using the method of the in the stopped heart or the own pump with the artificial blood circulation. And here are the results. So average duration of the circular arrest was about 45 minutes, and the temperature we decreased it for less than 22 degrees. And of course, the retrograde hypothermic cerebral perfusion we provide in all patients. Here are some demonstrated things. We used the prosthetic for aortal arch and for descending aorta. Here are some stages from the surgical part. In 4 cases, the patient underwent supracoronary replacement of the ascending aorta. In one case, the aortic root replacement as a Bentel de Bono surgery. In one case,